So we have an exciting program for you today. The first is going to be a short overview of the pilot and feasibility program. Then we're going to have a presentation, a short presentation for a few of our awardees. And I think it's going to be quite interesting at the end. We're going to have a panel discussion on what worked and what don't work for taking pilot data to the next level. So now I'm pleased to have the opportunity to introduce my friend and ADA colleague, who is going to be our keynote speaker today, Dr. Marlon Pragnell. He's the Vice President for ADA for Research and Science. So in this position, he oversees the research program at the ADA that, as you know, has been there for so many years, 40 years. And he also, I think it's amazing what he does. He is in charge of the annual scientific sessions. So every year we have this ADA session, and Marlon worked on that. I hope that you guys are going to join us in San Diego in June with the ADA meeting this year. So Marlon is a neuroscientist. He is a PhD who did his training at the University of Iowa, and then he did some postdoctoral training at Columbia University in New York. He's very well known in the world of diabetes research. He has done extensive work on diabetic complications, especially on prevention and recognition of preserving kidney function and retinopathy. He's also well known because he was involved with JDRF project on the artificial pancreas. So today his lecture is entitled Funding Research to Prevent and to Cure Diabetes and to Improve the Life of All People Affected with Diabetes. Marlon, thank you so much for coming, and so nice to have you here.
So thank you very much, Guillermo, for the really kind invitation and the kind hospitality here. Came in last night, had a wonderful dinner with colleagues, and it's lovely to be here in this, what I understand is a brand new building, a beautiful building. And so what I'd like to do today is, how do I do this? Let's unmute. Is there a... Did I just press the screen? Touch screen. So what I'd like to do today is talk about funding research to prevent cure diabetes and to improve the lives of people affected, all people affected by diabetes. So that's ADA's mission. ADA's mission: prevent, cure, and improve the lives of all people affected by diabetes. But I want to kind of add a little kind of area that I work on, which is more to do with how we fund research to accomplish that. And also talk a bit about, as Guillermo mentioned, very much involved in scientific sessions, so I'll talk a bit about as well what we're doing there. So here's the team, the ADA Health and Science Leadership team. Are these kind of tags going on the top? I'll try and close those. So we are, obviously our leader is Dr. Bob Gabay, Chief Science and Medical Officer, with Nicole Johnson, who's our VP of Operations. Me, I'm Vice President of Research and Science, again, focused on research programs and also on our scientific sessions. Nuhal's here, you've probably heard a lot about the standards of care. She leads those efforts, and also two efforts around professional education. And then we have Laura Hieronymus, who focuses more on the efforts around engaging the community, individuals with type 2 diabetes, more education and outreach. So our focus, basically want to increase the risk awareness of diabetes, funding innovative research, improving medical care, and engaging the community. And these are kind of the key goals of everything that we do. We focus on this. And really, we do this because we're in the middle of an epidemic. It's shocking that nearly 1 in 2 people in this country have either diabetes or pre-diabetes. Over 37 million people have diabetes. So many of them are not even aware that they have it. 96 million have pre-diabetes. And again, so many are unaware of this. And it affects every community, everywhere. Some communities more so than others. You can see in the south, people are more affected, but even in rural communities where there's very little access to clinical care, the Native American population, for example, and then there's lack of physicians to take care of these people as well. So lots of challenges. And diabetes affects everything. It affects every part of your body, eyes, kidneys, vasculature, and your family, and all the interactions and so on. It's just all encompassing. And that's why it's so expensive. A huge amount of money goes into healthcare. A large portion of all the healthcare dollars that are spent on treating diabetes complications. They're saying it's twofold higher costs for people who have diabetes and those without. We're actually working on this. We have an effort going on to kind of update these numbers. So we'll in this year we'll have a paper in diabetes care to kind of provide more updates on these amounts. And then primary factors. There's obviously age, genetics, and ethnicity, and so on, but so much of diabetes is behavioral. It's access to care, it's poverty, it's lack of outdoor space, places to walk, lifestyle, access to unhealthy food and physical activity. All these challenges that really are critical areas to focus on. And if you look at obviously the CDC reports and see, this is uneven. We're seeing people who are Black, Hispanics, Native Americans are disproportionately affected. Also to lower education level, people that have lower levels of education, people that are least able to take care of themselves in a sense are the ones that are most burdened by diabetes. And also to lower income levels. So huge health disparities exist across all areas that really create challenges and are pretty ways. Improving these would be clear ways to actually address some of the issues around diabetes. So our mission, you've probably seen this before, we want to bend the curve. The idea being that we want to stop this pandemic, reduce the amount of diabetes, bring people together, educate people, create programs, not just have therapies, but also to ways in which people can better understand how to take care of themselves and their families. So we have a large footprint. Our footprint, we have 20,000 professional members, programs in all 50 states, many volunteers and donors. And as professionals, we're probably one of the first contacts you've had probably is coming to our ADA scientific sessions. This is the big meeting we have every year. I'll talk a bit more about that. This brings all researchers together across all disciplines to come together to discuss, to collaborate, to identify new strategies. And a plug here, registration just opened. So please go to our website, register and come. It's going to be a really exciting meeting, and I'll talk a bit more about some of the kind of cool innovations that we have implemented there. You've also, as professionals, you probably know about our standards of care. This comes out every year, and it's a huge effort by a committee that looks through all the latest data, all the research, to identify what clear guidance, what new guidance should be there. And they go to great lengths to decide how to weight that guidance down to the very wording. And this has become one of the most respected sources of standards of care in the world, and cited, all over the place. This is the last one that just came out. I encourage you to have a look at it. It came out earlier this month. And so that's one of the areas trying to improve standards of care. We have, 40,000 certifications of health certification practitioners delivered by ADA in person, online. So a lot of in-person online education, many diabetes education programs. One of the major efforts is kind of educate professionals in standards of care in diabetes. And I want to put a plug in here. Right after our standards of care comes in, what we do is we hold a clinical update course. And this registration is open. It highlights the key highlight here is to understand what are the latest developments, what's the latest guidance around the diabetes care, standards of care, what's new, but also to a lot of other interesting, very relevant discussions, presentations around key areas in diabetes. So I really highly encourage you to come to this. It's not far away. It's just in Tampa, and it's happening on February 10th through 12th. And so as also professionals, you've probably seen many of our journals and hopefully published in those as well. These are some of the latest kind of covers. These have very high citation indices, people highly respected, and we, they're go-to journals to see what the latest research is. So these are aspects of some of the professional things we provide to the community, but we also actually provide a lot of outreach and guidance to people with diabetes themselves. Here, for example, guidance for people who just have diabetes, who just have just developed it, both in English and in Spanish. We have guidelines around how better to live with diabetes, how to take care of yourself. We submit monthly newsletters. A lot of people have engaged in this. You've also probably heard about Project Power, ways in which ADA can help families who have young children who might be at risk, programs where these children can learn about better healthcare, better diets, how to live better, more activity. And so these are really important ways in which the ADA reaches out to the community. And also, you've probably heard also diabetes, no diabetes by heart, and it's a partnership with the ADA, the American Heart Association, to engage people with diabetes to know how to prevent cardiovascular disease and so on. We have camps. So like 6,000 kids a year come to diabetes camps around the country. I think these are largely type 1 and some type 2, where kids get to feel normal and spend time with their peers. We also have aspects around education, how better to eat. Like for an example here is Diabetes Food Hub, where people can go online to understand and find healthy recipes, plan recipes, and plan their grocery lists. And so these are resources we provide to the community. You also heard about the ADA walks, where to increase awareness around physical activity, but also an opportunity to raise funds for things like the research that we support. These are very important. And, back in, I think, 2019, before the pandemic, there were like 10 different events and over 7,000 participants. And then you've also heard about Tour de Cure, where you have people run, ride, walk to shine light on activity, better healthcare, and also on fundraising. Importantly, the diabetes risk test. This is a risk test that's partnered with the CDC to kind of allow people to take just like a 60-second test to see where they fit in terms of risk of diabetes and whether they should go and get guidance, go and reach out to their clinician, their doctor, to see what their next step should be. Also making schools safe for children. These are efforts to make sure that children in school have access to insulin, glucagon, and schools are aware and are supportive of those efforts. We're also involved in the DRC, which is the multi-organization effort to kind of make sure that people who live in zones where there are natural disasters like hurricanes, fires, earthquakes, that there are opportunities for them to have sustained access to their therapies. Another important aspect of ADA. So there's so many different parts of ADA that are critically important for kind of getting out the word, bending the curve. We also have advocacy. We have a team in Washington, D.C. that are focused on areas trying to increase state and federal funding for research programs, fighting discrimination, making sure there's an awareness of the challenges around health disparities, and promoting policies to prevent diabetes. And then there's also bringing DDP, the national DPP to underserved communities as well. So that's an effort as well that's actually led more like by Laura Hieronymus. And also too, we have a large online presence, and so lots of social media, a lot of access to our website, which we're actually in the process of upgrading, and communicating, trying to get the word out to both professionals and also to lay. But we want to get back to our focus, and the focus of this is more like the research aspects, and as you can see, one of our 4 key areas is funding innovative research. And a lot of people don't know about what ADA funds. It's not that clear, so we want to make it clearer and create more of a roadmap and clarity around how we do that. So advancing research is really a founding mission of ADA right back in 1940, when the initial founders met together in Cleveland, Ohio. Part of the charter was to encourage and support clinical, experimental, and sociological and statistical studies by means of grants. So we have had focus on grant funding from the very beginning. And if you look through the previous journals, you can see for the last 70 years, ADA has been actually awarding grants. We don't have as much insight into the specific grants we funded way back then, but we have a lot more data around the more current ones. Importantly, our funding is impactful. What we're seeing is a lot of people, some really famous, well-known key opinion leaders. Some of them actually received their first grants from ADA. Really got their start with ADA. The grants there, we're seeing a high number of publications as a result of each grant, a lot of leverage. So people that get an ADA grant go on to develop data that can then help them get another grant, for example, a much larger grant from the NIH, for example. We get to keep these people, bright people in science and in diabetes research, and also too, they mentor others and create a broader community of researchers to work in this space, work in diabetes, to help bring this to these cures and treatments and preventions. So it is funded about $860 million in 4,800 research projects since about 1952. And you can look back on our website, you can see the various annual research reports, and one's coming out very shortly. So our focus, absolute focus, is to fund research to prevent, cure, and manage diabetes. And a really important part of that too is to grow the next generation of researchers. I just want to stop here because I think what we're having a challenge is actually having young researchers apply and get grants. We're seeing a lot of more senior research getting funding and so, but our last rounds of RFAs and so on have been very, very small numbers of postdocs. So I'd really highly encourage everybody here. The pay line is very generous and very, very good for postdocs. So if you have any, and you know any postdocs or any candidates and so on, please send them to our website to look and see for RFAs, and please apply. The last few years have been quite challenging across the board for everybody. We went through the global pandemic. Funding was very challenging. And that also allowed us to kind of look back at our research programs and see how can we be more impactful, be more, address things more rapid on a rapid basis. And so what happened was we pivoted and we started saying, instead of just funding these just generic grab bag of research, we said, what we're going to do is move to more targeted. more critical research. We want to get to have more critical research and also close to the patient. And so what we're seeing is that ADA is shifting more and more from a more basic direction of research to actually funding more research, translational research. Research is very relevant to people in this room. So we put out one of our first targeted research efforts was in COVID-19. We funded around 10 grants, $1 million for 1 year. It's very successful. You know, the urgent need to understand how people with diabetes were affected by COVID and how to mitigate that. Quite a number of papers came out, areas that were looked at from areas, how are beta cells themselves actually affected by COVID, and how the infection could actually change the function of those beta cells. And that we found that Shubing Chen saw they were more alpha-like. So we saw these kind of changes. Below you can see the various kind of media that she generated from some of this really cool research. Tracy Lynn McLaughlin, she focused on how COVID affected fat cells and immune cells in those in that tissue. And again, she was kind of highlighted in the New York Times in terms of how COVID could actually hide in the lipids in the fat, and then immune cells there could actually generate a cytokine immune storm from there. And also people that were working on trying to understand what are the prognostic biomarkers that would bring people, people who had diabetes, what were the factors that could predict their outcome for things like acute respiratory distress syndrome. So quite a lot of cool information. But on the heels of that, what became so clear was this huge disparities, health disparities in diabetes. Just the whole pandemic just opened up this whole awareness that some people were not getting the care they needed, and there were the disparities. So we actually launched an RFA, and this is actually more and more now where we're heading. ADA was very much involved in kind of raising the awareness about health disparities. We put together a health equity bill of rights, the right to access insulin, the right to avoid amputations, the right to the latest medical. These are basic human rights. And this is what guides a lot of ADA's efforts. And part of that also too was the motivation around the RFA that we published. So we funded a number of investigators in health disparities. This was our first pass. As we become more and more focused and more strategic and targeted in our RFAs, we're looking to get more and more applications, hopefully from people in this room as well, going forward, to fund and to bring forward. Again, there was also as we move more and more towards translational and less from like the basic science, things like how can we better prevent diabetes? We have this pandemic going on. We need to be doing something better about that. And so let's put out some RFAs to see if we can get some good, useful, helpful ideas around nutrition and lifestyle, better nutrition, better lifestyle, more activity, and so on. So we put those out, and we did those reviews, and those grants are being funded. They funded last year. We also are very much involved in precision medicine. This is the concept of a medication, a medicine might work for one person, but it might not be as effective for somebody else. And so, and this is something that we've been kind of collaborating with the ESD. And so we've put out an RFA there. More recently now, we have RFAs in improving lives of women with diabetes, which is a huge gap, we feel. And just looking at like the recent data, there's so much data, but just looking at this data around the pregnancy outcomes in the Today trial, shocking. Looking at these women, 1/4 of these women lose their babies. 65% report complications, 32% preterm birth. Really dismal results. 17.9% macrosomic. So that's just only a small kind of aspect of around women's health. What you'll find when we put our RFAs, they're rather broad. We're not very prescriptive. The approach we take is we'd like you to submit along the lines of the RFA, but we say, no, don't submit the full application. Submit an LOI. Don't spend all the time in the application. Just get the idea across. And then what we do is we have a committee that reviews that and then identifies those who should come forward for funding. Another thing too we just had out was the tackling the youth onset type 2 diabetic epidemic. This is disproportionate. This is crazy. This is disproportionately affecting Black youth, Hispanic, and Native American. So we're trying to understand there too what ideas are out there that we can address some of these issues. People with young youth onset have more rapid decline in beta cell function, for example. But what you can see through all of these are health disparities. A theme of health disparities runs through all of these because clearly you see the people who are the most affected are Black and Hispanic. So this is the kind of the approach. You look for all of our RFAs going forward, you'll see a kind of a theme of health disparities run through them. We also had a recent RFA out on supporting the psychological needs of people with type diabetes. So many people have emotional, mental health issues that impact on the way their care and their glucose control. They say that only 20 to 50% of people with diabetes who have depression even get that. And also we're seeing high levels of suicide ideation, for example, in people with type 1 diabetes, with moderate to high levels, and 27% of T1D teenagers, 8% think of suicide. So these are kind of key things that need to be addressed, and these are within the scope of our RFA. And if you read our RFAs again, very broad, talk about disordered eating, suicidal thoughts, diabetes and stress, diabetes, depression, and so I would highly encourage you to keep looking at our website. Look to see, we're coming out with kind of a standard cycle of grants, of RFAs. And also on the website, it gives you an idea of what kinds of mechanisms we have and the duration of the grants. And so any questions, just reach out to us. Our team was very happy to help and guide on what our mechanisms are and what may or may not be eligible. I also want to talk a bit about our pathway to stop diabetes. This is a really exciting program that we have. And this is really, really top scientists, top researchers. And we'd love to have submissions from people with health disparities, for example. The idea behind this mechanism we have is it's obviously focused on the science, but we really want brilliant young people to create the environment for breakthroughs. So the concept of that is taking people, identifying people, and these are people that have been nominated by their institutions, one per institution. They come together, we look at them, they propose their research, but then we look at them as what's their potential for producing research, and how can we further accelerate and just create this environment for success. And so what we do is we pair them with mentors. We've put together a stellar group of advisors, what we call the mentor advisory group. And these individuals and it's very, very competitive, but these individuals who get funding then are paired with mentors. And these are also the review group. We're moving more and more towards translation. You'll probably notice a lot of these people are basic scientists and we want to now have more and more representation of translational, even like implementation science, things like that. So that's our goal going forward. Right now we've funded over 35 of these. These people get upwards of $1.6 million for like 5 years of research. Each one is just very carefully vetted, and then we provide mentoring advisors. Also, we bring together in a community to discuss research and so on. And this way allows them to shine. These investigators, they provide that, they submit their research. We fund it based on the research, but we don't hold them to that research. There's an incredible amount of flexibility here, where these investigators can just shine and take whatever the path, because science can take you in different directions. The idea is that this will take them and they can decide on the path forward with mentoring. So what we've had so far is about 34 of these have been funded, lots and lots of nominations from individual programs, patents filed. And this has been a springboard for these investigators to kind of go to the next level. Many of these have kind of had significant career advancement. 16 of them have developed startup companies and tons of publications. Let's give you an idea of some of the investigators and the titles. What we're hoping to see in the near future is kind of titles more around translation and actually the patient, and would love to see more aspects around health disparities be represented in this group, and this is a real priority. So, but you have Tiff looking at genetic factors, spends lots of time in Africa. Meilan Shang, who's looking at issues around how to identify better therapeutics for foot ulcers. Michael Stitzel from the Jackson Lab, Sumita Penethur, looking at things like better pumps and sensor technology. Ebony Carter, looking at ways in which you can benefit, improve women's medical outcomes with gestational diabetes. And Zheng Gu, who's looking at things like smart insulin and so on. So this is a cycle we have as well. And I really encourage people here to think carefully about that, because we want to see research from groups like these where, you can, again, the institution has to kind of nominate the one person and they get compared against everybody else. But again, we're putting an increased amount of effort on translation. So please consider that when you see it. We're actually announcing some 2 awards very soon. We have press releases coming out, and I'm happy to say that one of those is actually ready on kind of implementation science and so on. This cycle will start this year. Keep an eye out on our website, and you'll see this funding whole process kind of culminate towards the end of this year. Look at our website. You'll see we have a kind of a cadence now to our review process. We want to kind of give people a sense of, this is going to come out at a certain time. Look for RFAs, apply to their RFAs. So as we kind of grow and develop our program, our research program, we want to kind of make people more aware of what we fund and how we fund it and so on. More education around that. And also too, as we fund the research, we don't just kind of leave it at that. What we want to do now is also as well put even more effort now into engaging the researchers. Since we have RFAs that cover certain areas, we're bringing groups of these people together to discuss their research. And this is an example of one we had in Washington, DC. We've been leveraging our DC office to have these, because DC is a great area to kind of bring in people from NIH, for example, as part of the workshop. And so this is sorry. So we've been we've been doing these, and we're doing more of these workshops as we progress with these RFAs, and we have like a networking dinner. People come together, small, intimate kind of. The idea being that identifying synergies, people come together to meet each other, to meet ADA staff, and also to meet NIDDK as well. We have key chairs, prominent chairs that come and provide feedback and discuss. And then also special guests. So for example, I think you might be familiar with Pamela Thornton came as well, and also to Miranda Brodney, and they were actually very helpful in kind of, because what we're seeing is we're funding our research, but we want to have them on the radar for the next stage of funding. And so, have them understand ways in which they can engage with NIDDK and kind of create an environment where they feel comfortable. to connect and to get into the state where, this is a kind of should be a seamless transition where they should feel free to talk to NIDDK program directors and kind of on best approaches, best strategies to kind of get that next level of funding. And these great sessions, we have wonderful workshops. We want to do these on a regular basis. Rapid fire presentations, not long-winded presentations, lots of engagement, lots of challenge talk, lots of time for discussion. So that's the model that we're using for all our future workshops, leveraging the DC area to kind of bring in experts and so on to really create a sense of community among our RFA, our recipients, and get them teed up and on the radar for their next funding. And so that's something we're really pleased about. We're also kind of reaching out to our investigators. We have a Spotlight to Science, so if we reach out to you, please accept our invitation to be interviewed. We'd like to kind of have as many people as possible kind of talk about their research and on a Facebook Live setting. So kind of introduce these people to the larger population. So coming back a bit now to our focus. It was increased risk and so on, engaging community. So our scientific sessions is engaging the scientific community. And we've been having this meeting, which I hope all of you are going to come to. We've been having this for 82 years. This is the first meeting was in 1940. And we've had them all over the States, all the top quality science, top quality research. And so our last one, we had 2 years of virtual, which was really quite challenging because, the way to kind of come to meetings is to be in person and chat and connect. So we were so thrilled, and everyone was so thrilled to come back in person in New Orleans. And so if looking back at the last virtual, we managed it. There was no compromise in the quality of the science. All the abstracts were there, all the presenters and so on, but we were a bit siloed. So people weren't really there engaging as much as we could have in person. So we were thrilled to have our first hybrid meeting in New Orleans, and we had people in person. The attendance was somewhat reduced because we also provide this virtual option where people actually were able to attend virtually, and there were people in China and other parts of the country, other parts of the world that really couldn't travel because of still much of the world had challenges around COVID restrictions, but people participated in person and online. And this, I think, is probably the model for us going forward, where we'll always probably have a hybrid meeting. In person, the poster sessions, people actually got to talk to each other as opposed to just go online to see posters kind of in series. And so a huge step forward, and we were so thrilled to be able to do that. One of the cool things about the scientific sessions is all the great science that comes out, and there's so much science. But some of them even rises even more exciting, and that is, for example, the tirzepatide session where you had on the Ceremount one that was like packed. I mean, it hit the news waves, and everybody's talking about weight loss and all the different various incretins, and we're seeing these twincretin, and we'll see at the next size sessions triple incretins and so on coming out. And this meeting is an exciting meeting to come and connect with your colleagues, but also just be on the front lines of the latest science that comes out, be in the moment there, and enjoy the excitement of all the latest. And even we have posters, for example. We even had a poster last year that was simultaneously published in New England Journal of Medicine. So then you have these obviously excellent ones, but then you have so many others, posters and presentations that really could allow people to come together to discuss, and also to develop collaborations, new ideas and strategies and so on. So again, really I recommend come, make your booking. The registration just opened yesterday. You can join virtually, but you'll have a much more engaging, exciting experience if you come in person. And we've done a lot of kind of modifications for next year. We've the pandemic has allowed us, people are doing all kinds of different things and innovations and so on. We've took a hard look at the scientific sessions, and one thing we want to do is make it much more interactive, more engaging. What you'll see is we turned it from a 5-day meeting into a 4-day meeting. There was a lot of people just said, well, let's not bother with the last day, So what we did is we removed the last day, but then we also said, well, let's make this a more of an educational experience. And the way we did that is let's make these sessions a bit shorter. We had these long 2-hour sessions, and we've been truncating them down to 1.5 hours. We put a lot more emphasis now, telling all of our speakers, let's have more discussion, more engagement, more connection between the speakers and the audience. And so what we've done there too is said, the way we can do that is have more panels. So we're doing more panels, we're doing more debates, for example. Debates are very exciting, so we're doing those. We have a kind of a Shark Tank kind of entrepreneur competition that's happening on the Saturday. It's going to be a great meeting, and it's the committee's worked so hard. All the experts have worked so hard to put together a really nice meeting, and I can guarantee it's going to be really cool. So please come to that, sign up. Please come in person. If you can't come in person, come virtually, but you'll really have a much better time in person. So with that, I just want to thank you for the time. And if there are any questions, people always have questions about grants and so on. Our team is always very happy to help out. And our goal is our biggest goal is to give out the money to the best science and the best research. So the better the grant you can put together, the more you can tell us tell us back what we're telling you, aligned with our RFAs, carefully written grants. It's a thrill to be able to fund with grants. And so we're looking for those from the community and also from people in this room as well. So thanks so much.
So I don't know if any one of you has any questions or comments. The other thing is that the ADA has national committees. And for the young people here in this audience, it is good to be part of these national committees for promotion. So if you ever think if you're an assistant or you're going to be an assistant, it's good to be a national committee. We have 9 or 10 national committees that you can apply. You can email me or email Marlon, and we will put you in contact and the right committee for you. So thank you so much for being here.
So I'm Dr. Erin Ferranti. I'm an assistant professor in the School of Nursing next door. I am part of the diabetes group. I'm on the socio-ecological and behavioral core for health equity. But today I'll be sharing with you about the pilot and feasibility program. So the aim of the pilot and feasibility program is to help junior investigators transitioning investigators to engage in interdisciplinary diabetes translation research in our region. Our focus is largely health equity, and we have an enormous group of core faculty who are nationally recognized experts who serve on the team. So, as I said, the aim is to help junior and transitioning investigators. So the pilot awards fund pilot projects and micro grants. They are individual and group-based research development activities to support theoretical underpinning, conceptualization, and design of proposals, and then also to engage investigators in multidisciplinary focused diabetes translation and health equity research through career enhancement services. So not only funding pilots, but career development as well. So we funded numerous projects in 2022, some of them also funded by the ADA. So we're very grateful to the American Diabetes Association and Dr. Pragnell for that. So as you can see here, they run the range from looking at health disparities in weight gain prevention among youth, Dr. Marshall looking at glucose monitoring in primary care, Dr. Kate Winskell, who we'll hear from in a little bit, looking at technology and the use of smartphone apps to improve glycemic control. Dr. Lisa Johnson, who we'll also hear from today, focusing on identifying strategies to reduce postpartum diabetes screening gap among women. with a history of GDM. Dr. Sugala, also focusing on maternal health, which speaks to my heart. That's my area as well. So looking at the DPP maternal, it's a part of the DPP in doing a pilot home environment for, excuse me, I can't talk, intervention for new moms. And then finally, Dr. Yang, looking at longitudinal treatment outcomes for children with diabetes. So, you know, looking at adults, maternal health, pediatrics, so it really runs the gamut. There's 2 levels of funding. The $30,000 per year focus is on exploratory feasibility informative diabetes health equity studies. So looking at generating preliminary data, qualitative field work, secondary data analysis. And then the second level of funding is higher at the $50,000 level, more focus on prospective studies. So again, getting preliminary data, pilot studies to facilitate external grant submissions and you know, grow that work. So who's eligible for pilot studies? Any faculty from Emory, Morehouse School of Medicine, and the Georgia Institute of Technology. They can either be early career, so to build up eligibility for NIH submission, or they can be already established investigators who are transitioning into diabetes. So have work in other areas, but now incorporating diabetes work. So the areas of research are largely in translation, as we've sort of talked about, and the areas cover diabetes, complications, diabetes and long COVID, post-COVID, pre-diabetes and metabolic syndrome, obesity prevention and treatment. So the stages of translational research are T2, 3, and 4. And so T2 is translation to patients, T3 is translation to practice, and T4 is translation to the population. So those are all the levels at which the pilot funding covers. So important dates, the letter of intent for this current cycle was due November 30th. And right now we're in the midst of studio consultations. So that I have a slide to talk about that, but that allows potential investigators to engage with the faculty in the core, the different cores, to identify how to really improve their project or engage, you know, more health equity or whatever their focus is, kind of help guide their application. So applications are due February 15th, and the anticipated start date for this round will be the 1st of June. So as I mentioned, the studio consultations provide investigators the opportunity to present their research, and it allows established faculty to give them guidance and tips for how to, you know, improve their application. All right. So now I have the wonderful opportunity to introduce some of our pilot investigators. And we have 3 presenting today. And what I will do is introduce each one before their presentation. They'll be talking for 8 to 10 minutes each with an opportunity for questions. So we'll allow for that at the end of each of their talks. So Dr. Kate Winskell is an associate professor in the Hubert Department of Global Health here at Rollins. She specializes in the development and testing of behavioral interventions with particular focus on mHealth platforms. To date, her work has focused on HIV, and the study she'll present today is her first experience in diabetes translation research. And it's a field that she's becoming very passionate about and hopes will be a central part of her research portfolio. So Dr. Winskell.
Thank you, Erin, and thank you for the opportunity to share this work with you today. We really look forward to your feedback and your response. We're in the development stage and we have much to learn from you all. So I'm presenting here on behalf of Francisco Pasquel, who's here today, and also on behalf of Alicia Ferranti, who's joining us via Zoom. So just a few words of background. Our keynote speaker has already very eloquently outlined the profound disparities in diabetes outcomes, so I don't need to go there. Second element of background is the revolution in diabetes care that is happening as a result of continuous glucose monitoring, and the fact that access is growing, with it now being standard of care for all patients on insulin. but it's not growing fast enough, and it's growing very, very unevenly. So third element of background, the disparities that exist in access, use, and continued use among non-Hispanic Black patients in particular. So huge amounts of work to do there. Finally, diabetes self-management, education, and support, DSMES, very strong evidence base for a general population, but underused. So a great deal of work to do there in terms of improving access, improving relevance, etc. And this is where our study comes in. So our goal is to optimize the impact of CGM and also DSMES among insulin-dependent, low-income African-American patients at Grady. So how do we intend to do this? Well, through using user-centered design approaches, co-creating with Grady patients, providers, and other stakeholders, a CGM-linked smartphone app to improve glycemic control and self-efficacy for diabetes self-management. So the app is theory-based. It's sensitive to health literacy, to social determinants of health, and to sociocultural preferences. And in this way, we are seeking to address some of the key barriers to the use of existing apps by this population. So as many of you will know, there are a lot of diabetes-related apps out there, but they tend to focus on tracking diabetes-related metrics in ways that presume very high levels of numeracy and health literacy. Often they're behind, or their key features are behind a paywall or require insurance coverage. They're generally not integrated within the healthcare system, so people have doubts, they lack confidence in these apps. In addition, they're often burdensome and unappealing and overly complex. And as a result, we're seeing this broadening marginalization, this increased disparity in relation to digital health. And this is what we are seeking to address. So we're using user-centered design approaches. This, in a way, is where intervention design meets the ethos of community-based participatory research, but with a very strong focus on implementation. So how can we ensure that we result in a product that has the highest likelihood of being picked up, of uptake and of impact? So we start off with generating an empathetic understanding of the realities of people's lives. What are the barriers? What are the facilitators in their lives? How can we make sure that whatever solution we come up with really fits into the realities of people's lives? Second of all, co-creating with the stakeholders, in this case, patients and providers, ideas, making sure that it's very much rooted in their experience and their needs. And finally, hopefully, well, first of all, constant iteration so that we get a better and better product with a view to optimal implementation. So to take us back to that inspiration stage, the empathy generating stage, we had an idea that this needed to be an app, that it needed to be a digital solution. There's evidence that DSMES, the access to DSMES can increase dramatically through the use of technology. Right, so you're overcoming some of those structural barriers. And in addition, of course, CGM is linked, is a technology, and most people access it, or many people access it these days through an app. So we discovered in a survey with Grady patients that, first of all, 56% of our sample had CGM access. We were sampling for CGM access to some extent. We wanted a balance, so that's no surprise. But we did discover that overwhelmingly people were using the Abbott Freestyle Libre, which is the CGM that is most affordable. 95% owned a smartphone, and many, I can't tell you the exact number, but most were using a pretty recent smartphone. So we weren't anticipating major barriers in relation to the smartphone technology. 2/3 were using Android, and 77% would find an app to support them in managing their diabetes helpful. So to come back to the Freestyle Libre, we decided, drawing on this data, to reach out to Abbott, and we have a nice dialogue going with Abbott. They've very generously given us access to their application programming interface, their API, for the Freestyle Libre, and we are working with them. We're planning to build this app for the Freestyle Libre 3. So the new Libre app, which doesn't require you to flash in order to get your CGM data. So it's a continuous feed to your cell phone. In interviews with patients and providers, the most common recommendations were that people needed help interpreting their blood glucose patterns. They needed resources to help support carb counting, customizable reminders for exercise, prescription refills, etc., and interactive educational materials, and ideally games with rewards. They wanted something motivating. So in the second phase of our user-centered design is the ideation phase. We have come up with provisional designs of the structure of the app and of individual components, and also wireframes, so provisional images of what the app could look like as a springboard for our co-creation process. And we're currently conducting interviews and focus group discussions with a pool of Grady patients and Grady providers. And we'd like to share some of those findings with you right now. First of all, the structure of the app. So as we conceptualize it right now, we see it as very much integrated within the health system. So setup is done in dialogue with a certified diabetes educator. In this case, in the Grady case, obviously, if we're looking at different environments, that might be somewhat different. There will be an assessment that will help with the tailoring of the app, particularly, for example, in relation to diabetes type. Also, this is the time when reminders can be set up and goals set up, goals established within the app in dialogue with the diabetes educator. These goals will garner rewards. Achievement of these goals will garner rewards, as will success on quizzes linked to these interactive educational resources. Perhaps the most distinctive component of the app, a CGM data review. And that's where I'm going to focus for the rest of today. And also real-time nudges in relation to the CGM data. Okay, so in terms of our results so far, people are enthusiastic about the concept and the structure. There's universal excitement about the rewards component. People are very eager to demystify the squiggle, i.e. the CGM squiggle, right? Some feel able to devote more time to the daily CGM review than others, and some anticipate having greater tolerance for reminders than others. In short, a high level of customizability is desirable and possible. The app should also have the look and feel of a lifestyle app, not too clinical, right? It needs to be motivating. They need to want to use it. So first of all, some images. Goal setting. This is our provisional goal setting setup. We're also experimenting with some little images in place of those icons. It aligns with the 7 self-care behaviors of the Association of Diabetes Care and Education Specialists. Problem solving and reducing risks are really built into the structure of the app. And monitoring is, of course, using the CGM data. I think that the other components are pretty self-explanatory. So now on to the CGM data review. The idea is that at the time that is set up in the app, you would get a reminder asking you if you're ready to do your end of day CGM review and earn some rewards. And you would be told what your time and range for the previous 24 hours is. Also some educational components built into this. So explaining that your aim is to achieve the highest level of green as possible. And then we go into your own CGM data and how your sugars have changed over the course of the day. Again, explaining what that graph means. Within the Libre, it's not color-coded, okay, which is why I think the squiggle needs some demystification. So we're color-coding the squiggle right now and running that by patients, and also helping people to interpret what that means, what the green zone actually means. So we then go on to the patient's own data and congratulate them for when they are in the green zone. Help them think about how they achieved the green zone and try to get some feedback on how well they're understanding that process. Also, then thinking about areas that they can work on. So where were their sugars highest? And understanding better why that might be. Okay, so let's say this person responds, I didn't take my meds. And to this question, why didn't they take their meds? They respond, I forgot. Then we can encourage them to set a reminder. Okay, if they were to say, I'm trying to make my meds last longer, right? And here we get more of the social determinants of health component. We would direct them to resources available through the Grady system to get cheaper meds or the Grady pharmacy, etc. Okay. So to sum up, we're going to continue our interviews and focus group discussions with patients and providers to fine-tune the design. We're then going to send our app requirements document to the Clifford lab, Gary Clifford's lab here at the School of Medicine, who's going to build the app for us. We expect that to happen in about 2.5 months, that we'll be able to provide that information to them. We're then going to do observed usability testing of the prototype. In other words, people will play with the prototype, we'll make sure the navigation is all right, and revise the app as needed. And then there will be a take-home usability testing where it's connected to a small number of people's CGM. And again, we'll revise as needed, and iterate as needed until we're in a position to do our randomized controlled pilot study, focusing on feasibility metrics and on getting some preliminary estimates of on glycemic control and also related mediators. And just to wrap up, we really believe that we hope that if this were to prove very promising, it would also have potential relevance for other areas around the world, especially for low health literacy populations. As somebody who's very new to diabetes, I'm acutely aware of the health literacy related dimensions of diabetes. Compared to HIV, this is such a complicated subject, okay? And I just feel we need to work together to do more to make this understanding more accessible. Thank you very much. So I think
I have one very question. So there's one. So the more specific question was, in the app, when they can select why their levels were possibly higher,
Yes.
and in that red zone, is there a select more than one option?
There is, and that's a great question,
Okay.
Swati. Yes, there is. So you would successively have to ask follow-up questions in relation to those.
Yeah,
those
because as I was
responses.
looking
It's
at those
really
options,
important.
I was like, I'm sure people would want to maybe select more than one in any given situation. Great. And then my other question was, you had mentioned the involvement of a diabetes educator. Is that the involvement of the educator in the development of the app, or can a user interact with an educator or another real life person as they're navigating the app, like a expert of some kind?
Not necessarily as they're navigating. So Alicia Ferranti, our co-I on this project, she is the diabetes educator who is very, very actively involved in the development of this app. We're not anticipating direct communication with the provider at this point within the app, though that is something we could foresee in the future. But we are very much anticipating that the app will be a point of dialogue within the interactions, clinic visits with the diabetes educator. And the answers that you saw to those questions, we're intending to provide a report to providers summarizing those responses. So they will know the primary causes or perceived causes of highs and lows, and also success in, achieving progress towards goals, right? So that can inform care.
Great. Thank you so much.
Thank you.
I am so sorry to cut off questions, but to stay on time,
Sorry, everybody.
we'll have plenty of time for interaction at lunch, I think, right? Thank you so much. Okay, next I'd like to introduce Dr. Jessica Harding. She's an epidemiologist with extensive experience in conducting chronic disease research at population and system levels in both academic and government settings. She received her PhD in medical research epidemiology from Baker Heart and Diabetes Institute in Melbourne, Australia in 2016, and engaged in a research fellowship at the Centers for Disease Control and Prevention from 2017 to 19. During the latter period, she focused on describing trends in diabetes and kidney disease-related complications in the US and examined variations in diabetes incidence and diabetes complications according to demographic, socioeconomic, and lifestyle risk factors. Here at Emory, she's working on improving data collection and quality related to kidney disease and transplantation as a member of the Transplant Health Services and Outcomes Research Program. So welcome. Do you want to give me a time warning?
Oh, yes, please.
At what time? 10?
Yeah. Okay. How do I find thanks, Erin, for that introduction. So this is some work that I'm going to present to you today that has come from a pilot and feasibility study, obviously. The topic here is declines in diabetes care during the COVID pandemic. And I don't think this really needs any kind of background information. I think we all have a sense of what we think this data is going to look like. So the main goal was to compare these diabetes care patterns in a pre-pandemic period and a post-pandemic period in a US insured population. And I kind of just want to spend a little bit of time talking about these methods, in particular, the collaborations that have been established between Emory and Kaiser Permanente, Georgia, in order to do this work, and some other work that I'm going to share with you a little bit later on too. So this has been a collaboration that we've established a couple of years ago. Kaiser Permanente data has historically been more difficult to access or more difficult to collaborate with. And I just wanted to raise awareness with this group that these collaborations have been established and data has been shared in a bidirectional manner between Emory and Kaiser Permanente. And you can do things like link data between Emory and Kaiser Permanente. So KP Georgia doesn't have their own hospital network. So a very large portion of KP members are being hospitalized within the Emory healthcare system. And there's opportunity to connect those two data sets together so that you can have longitudinal follow-up of KP members with all of their wonderful historic electronic medical record data that they have, and have hospital outcomes that you can gather from Emory healthcare. So I just wanted to flag that collaboration is existing, and Shivani, Venkat, and Mo and I have been involved in establishing that collaboration over the last couple of years. And so if anyone is interested in working with KP Georgia or is not sure who is the person that you should contact at KP Georgia, please let me know and I'd be happy to connect you. So for this particular study population, we identified anyone who had prevalent diabetes as of 2018 in the KP Georgia network, and those who had continuous enrollment through to 2021. So essentially, we're trying to establish who is the same group of people who experienced the pandemic from 2018 to 2021, so that we could compare their access to these diabetes care processes in the pre and post period. And this was just over 22,000 individuals. The definition for someone with prevalent diabetes was one of an ICD 9 or 10 code in the historical electronic medical records for diabetes, whether they had an HbA1c or a fasting plasma glucose record in the diabetes level, or whether they were taking an anti-hypoglycemic medication. We specifically looked at 7 diabetes care processes, including blood pressure, HbA1c, cholesterol, you can read. And then our analysis was specifically to do this pre and post kind of analysis, comparing what did the diabetes, who is meeting these annual diabetes care processes in the pre-pandemic period, which we called 2018 to 2019, or the post-pandemic period in 2020 to 21. We've used a mixed effects logistic regression and adjusted for age. There's not really any other confounders that needed to be adjusted for, because it's the same people in the pre and the post period. So this is what the population looks like. On average, they were about 60 years of age, a slightly higher prevalence of women, a slightly higher proportion of Black patients. 5% of the population did not speak English as their first language. Mean household income based on neighborhood level data was about $70.3 thousand. 13.5% of our population had a diagnosis of COVID in that post-pandemic period. Almost half had a flu shot in 2019. And these are the prevalence estimates of some other comorbid conditions that they had. I think broadly, though, I haven't put the general population in comparison. I mean, this is a health insured population. So on average, they tend to be healthier, have a higher income relative to the general population. And so this is what happened to diabetes care pre versus post-pandemic. So in the blue is the pre-pandemic period. And what this proportion is showing you on this figure is the proportion of people who are meeting annual care guidelines for these. So did they have HbA1 checked in both years, the 2018 and the 2019 pre-pandemic period? Did they have blood pressure checked, cholesterol, et cetera, et cetera? And what you can see is that for all of these indices, there was a decline, which is perhaps expected, in the number of people who are meeting these annual care guidelines in the pre versus post-pandemic period. And if you look at the table on your right, what you can see is that the greatest absolute declines were for blood pressure and for cholesterol. And if you put this in a model, these are what the odds ratio looks like, where there was a 69% reduction in people meeting blood pressure care guidelines in the post-pandemic period as compared to the pre-pandemic period. It's also very high for cholesterol. And if you look at foot or eye exams, which are perhaps not surprising given the need for physical contact for some of these like care processes that they need to measure. And I think the big question that we have moving forward is how do these diabetes, how is the fact that these people are not adhering to these guidelines in the post-pandemic period, how is that going to affect their diabetes management moving forward and their risk of complications? So there are some limitations to this study. As I mentioned, this is an insured population, so generalizability is a little bit lower. And we also included those who had continuous enrollment for that entire period. That means that, as I mentioned, we don't have confounders between the pre and the post-pandemic period because it's the same people. But the generalizability of this is a little bit limited. And I also think that this is both a pro and a con. Some of the barriers in accessing care are a little different for this population because access via health insurance is not a barrier that these people face. As a general, they have pretty uniform access to healthcare. We may have underestimated how many people were meeting annual foot exams because of the way we defined whether or not you had a foot exam. And we did not include incident comorbidity data in the post-pandemic period, which is something we would probably include in future analyses. These are intermediate outcomes. We don't know how lack of meeting these guidelines has led to changes in meeting HbA1c guidelines or risk of complications. And obviously we need longer follow-up for that. So in this sort of brief analysis, diabetes care was unsurprisingly significantly impacted by the COVID pandemic. But perhaps interestingly, the greatest declines were seen in annual measurements of blood pressure followed by foot and eye exams. And we do have some future research directions for this work. So we want to stratify by important subgroups, particularly around age, gender, and race, where we anticipate that these diabetes care processes will have been different in these subgroups. And we're also specifically interested, and I think this is one of the key studies that's actually going to come out of this work, is the impact of telehealth, which I currently have an MPH student, Sophia Ovida, who's working on this right now, is to see whether those patients who are accessing telehealth were more likely to meet these guidelines, and then trying to identify which subgroups of the population are more likely to be accessing telehealth compared to others, particularly in this population of people who have access to health insurance. We're also doing some work looking at what some gender differences might be in terms of both meeting annual guidelines and getting these checked, but also annual guidelines in terms of keeping your HbA1c under 7, and looking at this in men and women. And this is a piece of work that was presented in Portugal in December, showing that on average, men had a greater decline over the pandemic period, and that is resulting in a worsening glycemic profile in men relative to women. And finally, I just wanted to make a plug for for a future or a current research grant that Shivani Patel has spearheaded in collaborations with Venkat as well. We're really interested in the new cases of diabetes that are appearing in people who have been diagnosed with COVID-19. And we've established, again, this is another plug for our relationships with Kaiser Permanente, a cohort that includes KP Georgia, KP Hawaii, and KP Northwest. And we're in the process of pooling all of this data together, and we're going to do a series of analyses looking at whether or not pregnant women, people with type 1 diabetes, or people with sorry, let me go back. That's the wrong direction. Whether people with who've been diagnosed with COVID-19 are more likely to be developing incident diabetes, incident gestational diabetes, or incident type 2 diabetes. And that's work in progress that we're really excited to be doing right now. I'd like to thank all of the collaborators who've been involved in this, in particular Mo Ali, who encouraged this pilot and feasibility grant application and has been an ongoing co-investigator and supporter of this work. All of the other people who are involved in this work, both here in the Diabetes Center and also in the Health Services Research Center, where I primarily sit. And of course, the Pilot and Feasibility Award and also the P30 Center Award, which I think we can all agree is a wonderful resource and allows us all to come together and do this kind of work. So with that, I will happily take any questions that you might have. Giovanni?
I have a question about whether or not you have enough years of data to look at different stages of the pandemic and whether or not behaviors were different throughout. So what we're seeing in some of the national data is that there might have been.
Can you put the microphone up? I can't hear you properly.
Oh, okay. Yeah, my voice is so loud to my ears that okay. So I was asking if you have enough years of data to get a little more granular on stages of the pandemic and whether, for example, in national data, what we're seeing is some healthcare behaviors declined in the first year, but then bounced back afterwards. Do you have any sense of whether that's going on here? And also, do you have the data to explore it?
Yeah, I think that's a good point. So this, what I'm calling the post-pandemic period, we have 2 years of data, 2020 and 2021. I think we absolutely could be exploring this by month or quarter and looking at who is or who is not getting those things measured in those time periods. For sure, I think that's an interesting point. I think the reason we've not gone that granular is because the way I defined the outcome was whether or not you had the annual measurement, which was required. So looking at it by year is kind of how we've done it. But yeah, for sure, we could be looking at like rates of who is getting these outcomes, like getting these measurements by month.
That was great. So in the Emory system, we have what is called the Diabetes Management Program, and we track hemoglobin A1C greater than 9. And we started with somewhere around 20% in the whole system, like 40,000 patients. And we were able to bring it down to 13%. COVID went up to 20-something%, and now it's coming down.
Mm-hmm.
So I have two questions with that background. One is, what was the hemoglobin A1C? How do you track hemoglobin A1C? By the value or the lack of performance? Do you have any information? I mean, the main problem that we had is people didn't go to the lab to get a hemoglobin A1C, not the actual value by itself.
Mm-hmm.
So, and the other thing is, what happened after the 2021? Are you tracking information right now?
So I will answer the first question on HbA1c. So we have within the KP, I mean, it's a really extensive repository of electronic medical record data. So we have both whether you had an HbA1c measured, but also what that lab value was for it. Of course, the limitation of that is that it's only among those who had it measured. So that I think is a limitation, but broadly in that data, we see exactly what you're saying, that it sort of started out high when, you know, it's kind of doing this. We don't have 2022 data within the KP population right now. There's a data lag, but also when this grant was sort of funded, it was at the end of 2021. That doesn't mean that we can't get updated data up until 2022 to expand on some of this work, because I think one of our longer term goals, as I mentioned, is to see how whether this dip for just like 1 or 2 years is going to have longer term implications on people's management of their diabetes. So I completely agree with you. It's ongoing work with Kaiser Permanente, and getting updated data to look at that will be key. Thank you.
Okay, and our final presenter is Dr. Leslie Johnson. She's an assistant professor in family medicine at the Emory School of Medicine and adjunct faculty in the Department of Behavioral, Social, and Health Sciences here at the School of Public Health. Her research interests span examining risk factors for non-communicable diseases, evaluating the integration of chronic care models, and testing implementation strategies to integrate proven health interventions and practices into clinical settings. Currently, Dr. Johnson is the co-PI of a study examining the impact of COVID-19 on prenatal care and birth support, and is a co-investigator on several NIH-funded projects. In alignment with her growing body of research focused on women's health, Dr. Johnson's center-funded pilot project looks at enhancing postpartum care for women with GDM.
Right, thank you so much. So happy to be here with all of you today. So the impetus for this pilot study is really the fact that 1 in every 10 pregnancies in the United States is affected by gestational diabetes. And amongst these women, it's recommended that in that postpartum period of that initial 4 to 12 weeks, they're supposed to be coming back for a diabetes screening. Yet we see that only 2 to 50% of women are able to actually receive that care postpartum. So huge implementation gap, and something that we still don't have a clear picture of. Data is very limited in terms of mapping that to select states in the United States, and it largely draws from Medicaid data. Recognizing that in Georgia, we have the highest rate of gestational diabetes amongst the southeastern states. Unfortunately, we don't actually have a clear idea of what our implementation gap is in this area of clinical care. And so our aims with this pilot were really twofold. Taking a mixed methods approach is first to simply identify what is the no-do gap. Using PRAMS data, which it represents women in Georgia from a stratified random sample. We have surveys that go out to women 2 to 6 months postpartum and ask them a lot of different questions about their behavioral, clinical use, and their child's health as well. And so we wanted to kind of look through that data to identify how many women who self-disclosed that they had gestational diabetes are actually receiving that follow-up visit screening test. Look at the racial ethnic disparities that may be occurring there, since we see this largely on a national scale already occurring, and then look at some of the healthcare utilization indicators that are available to see if there's any associations with how we can get women back for these screenings. And then the second part is thinking through strategies to improve that gap. And so recognizing that much of the data that we have in the qualitative realm draws from the United Kingdom, we wanted to think more locally about how our participants would be receiving the care they are and how we can bridge that gap. So talking to both women who've had gestational diabetes and then also care providers from different disciplines to think through different strategies for innovatively addressing this gap. And so I'd like to touch more on my timeline briefly, because you'll see we don't have a ton of preliminary data to share today. We've had some unique challenges moving forward, mostly in the acquisition of the data. We're unfortunately limited that the PRAMS data set is the only one available that allows us to identify in our population of interest this specific indicator in postpartum healthcare utilization. So we applied for the data prior to receiving the grant funding, knowing that we wanted to go forward with these analyses in some way. And as you can see, we didn't end up receiving it until the end of December. So just before Christmas, that was my gift. So we've just now started our initial descriptive analyses of that, and we'll be moving forward with our subsequent analyses in the coming months. But in that time, we've been able to identify a wonderful trainee team that will help us conduct our interviews and recruit both patients and clinicians. And we've done some extensive work in thinking through our clinical indicators of interest with both fetal maternal residents and co-investigators on this grant. And so I think we've been really successful in that period before we submitted the data request in thinking through how we can best utilize this data, since it is unique. And expanding from what we had originally proposed of looking at the 2020 data, recognizing that they actually did fold that question in for the 3 years prior. So we now have kind of a larger cohort of over 3,000 women who were able to assess over that period of time. We've been able to engage different MPH, doctoral, and MFM residents across our different study activities. And then in that fall period, able to still pilot and revise in early January our guides. So we're very confident moving forward that we've really integrated all of these inductive topics that have come out and things that perhaps weren't captured in the literature based on the non-regional specific data that was put out. and including from the key informant interviews, the types of medical providers that we should be reaching out to. So, for example, we have some local diabetes care nurses where even though they weren't within the realm of postpartum care in any of the clinical settings we're looking at, are being connected postpartum to some of these patient populations, and were something that we're heavily advocated for to include moving forward. So we've been reaching out to kind of a broader set of clinical stakeholders in order to capture where these different kind of fragmentations of care are occurring in that warm handoff in the postpartum period. And then, of course, thinking through a broader recruitment plan, we've been able to actually establish both a clinical and a community recruitment strategy, which we're working through right now with our newly established cardiometabolic postpartum clinic partners. And so we're really excited because they just started in September and they've just gotten underway and have their systems in place that we are now able to pull specifically from their clinical records, individuals who have been diagnosed and are willing to kind of follow up in research studies. And so I kind of wanted to talk through some of those challenges that we faced, obviously welcoming input for future work in this area is how to avoid this. And some things that, of course, were unavoidable is that starting in the summer, we weren't able to easily identify students. So we'd reached out to several others, kind of trying to drum up interest in blending these interests in maternal health and diabetes care. And then working to, as I said, expand that PRAMS data set request to really allow us to go beyond measuring the care cascade and think through some of that postpartum healthcare utilization data and how these women have different clinical outcomes related to birth. And then because of some IRB onboarding delays, unfortunately, that fell within that timeline for us. We also were able to focus more on developing qualitative research approaches for our trainees who neither of which had any qualitative experience prior to this. So have successfully been able to complete that and allow them to pilot the guides as well with patients and providers. And as we said, the PRAMS data was a little bit longer of a delay the latter part of last year, waiting for that to arrive. I had never requested a data set from CDC as such, so I was unfamiliar to the processes for this, but somehow in there they switched to a new system and that got lost in the translation. So we were able to get that completed, but in that time, it actually opened up a different thread of thought that I think has cultivated a lot of ideas for further work, specifically trying to identify alternative national level data sets outside of a Georgia specific study site. And from that, we recognized it's not really easy to identify our outcome of interest in our population of interest. There's not many national data sets that allow you to link those two because they're often cross-sectional and they don't indicate previous medical diagnoses just within the antenatal period. And so this is quite alarming and actually has stirred up a lot of thought, and we're working on developing a commentary on how to bridge these gaps in quantitative data sets. Like we were originally looking at the NHANES data sets and NAMCs, and we're very hopeful that we could pull that clinical data to link it. And it's been shockingly challenging just to identify simple prevalence rates for these types of care utilization data. And so expanding our work in that direction. And then, of course, as I said, working through some of the onboarding processes and timelines of our clinical partners. We've actually been working more with local mom support groups to get word out there about getting participants from the community, revising our guides to better map onto our pilot work to see kind of the different topics that came out of those conversations that we weren't initially anticipating because the data was largely driven by international data and not US-based data. And then expanding our clinical provider recruitment strategy. And so I can provide a little bit of a glimpse into the data as we've looked at today. As I said, everything is quickly being put into motion, but for our quantitative aim, you do see over the 4 years of the data we received amongst these participants, a fairly consistent, except for year one there, 2017, we have a double rate of gestational diabetes. Unfortunately, that's the otherwise inconsistent piece here, but fairly consistent rate of postpartum diabetes testing being done. So about on par with the higher end of the national data, hovering around 50 to 60% of those women who are getting the postpartum clinical care that is set in the guidelines. But of these 12% roughly of women with GDM, we still see that 12% of them aren't getting that test just because they're not coming back for the postpartum visit. So we're already losing a portion of people right there at that follow-up point of care. And then 30% further missing it because they're not getting the test, even though they went to a clinical appointment. And so that's obviously a very low-hanging fruit in terms of something that we can intervene on to make sure that they're getting that test when they show up in the clinical setting. And so just to give you a little bit more of an idea of who these women are, we do have a fairly diverse group in terms of a number of sociodemographic characteristics. This population being predominantly African-American and white, one in 5 identifying as Hispanic as well, and then having a large representation of Medicaid insured patients with then private and a few government insured. But on average, our women are about 20 to 31 years old, but a very wide range in age represented here. So I think this is unique in that we do have quite a representation of privately insured, which, as I said, the current data out there really is focused on Medicaid funded women because that is the easiest data to link with birth certificate data. And just a glimpse into our qualitative data and how we're using that moving forward, because we only have been able to start data collection in early December. We have a limited number here, so that's why I say preliminary. But from the patient perspectives that we've been able to collect, I think there are some kind of unique barriers that have not been captured in the previous literature, mostly focusing on mental health, feelings of anxiety and overwhelm that may impede follow-up in the postpartum period, as well as comfort levels, bringing newborns into a clinical space, especially during a COVID pandemic timeframe. Some clinicians may have had restrictions on bringing the baby back with postpartum visit, but just wanting to, even if you're able to, obviously being apprehensive there, or potentially leaving your newborn with a caregiver at home, and that being the first time in which you're really away from your child. And that's something that hasn't previously come up in the documented barriers to attending postpartum visits and therefore getting this type of care. We also see that in general, it's not even so much of why they're not coming back, it's that there is no postpartum care. So kind of a broader overreaching issue across the population, as this is probably not specific to women with just GDM, but just a lack of overall contact points in the postpartum period, especially in those initial weeks after delivery, that women are really looking for more comprehensive, but also more touch points. And so kind of some frustrations there. And some of the data coming out of these interviews have helped us kind of recalibrate the timeline in which we're trying to speak to women in the postpartum period. So recognizing that so much is going on, and there's a lot of quickly evolving, perhaps health utilization issues, and especially for mother and child. And so we had initially said that within the first 2 to 3 years postpartum, we could speak to women, but recognizing that we really needed something closer to delivery. And so trying to keep it now to women who have given birth within the previous year so that the recall is much better for that timeline of events. And so from our healthcare provider perspectives, we see that there's really a lack of understanding about how appointments are scheduled during the delivery period. And so each person has given a different narrative of who is in charge and what they thought was supposed to be happening. Some have even said they have no idea how it happens. The providers put in the call for the test to be in, but someone has to schedule it for them to know. And this kind of triangulates nicely with our patient data because they're often saying that, okay, actually no one even told me. So obviously the test was put in, but nothing was communicated to the patient. And so there's really a push onto the patient then to self-advocate and make sure they're attending the appointment. Whereas the clinicians were saying, we know it needs to be done, but we don't know who's actually following up and making sure that those are scheduled. And there's certainly no one available to help make sure they come back for it if it is scheduled. There was a large perception that we're really missing the boat on postpartum care post-COVID because now we have this huge influx of people understanding telemedicine, but we're not using that to contact women in a time where it may be easier for them to stay home. It may be just a good touch point just to check in with them and see how they're doing in terms of mental health, in terms of recovery, checking in and perhaps thinking innovatively about ways to do diabetes testing at home, given these women have been checking their blood glucose levels throughout the pregnancy as a result of their diagnosis and are familiar with these types of methods and may be open to that. And then, of course, recognizing that transition to care post-delivery just needs to be improved largely. I think everyone was pretty on board with the idea that there's always more we can do, and just trying to figure out across disciplines how we could coordinate and streamline communication between providers in different spheres. And then something that was, I think, a large gap that was identified that I also did not see in the literature was looking at how women may not be coming back because they don't have a primary care provider selected before pregnancy, especially in some clinical settings where women tended to be younger mothers. And so they'd only ever been to a pediatrician potentially, or gynecological care was mostly what they're seeking out. They may not have someone to link back to in the postpartum period. And so potential area to address is simply just making sure that they have a PCP before they're leaving the hospital. So I will wrap up there. Thank you all so much.
We can, one question. We're running behind.
Yes, Megan.
Hey, Leslie, this is really interesting. I know she said one question, I'm gonna ask two. So my first is, with your quantitative data around like the proportion that actually came back and got screened or came in for a postpartum visit. Sorry. Did any of that vary by parity? Meaning if they had multiple pregnancies, kids at home, did that make a difference in whether they were actually coming for a postpartum visit? So an experienced versus inexperienced mother might, I don't know.
Great question. That's part of the subsequent analysis we have planned. So we have a bunch of clinical data as well as information about previous births or whether they had other high-risk conditions like preeclampsia or things that maybe have been signaled that they need to have more follow-up care.
My other question is, can you go over what the screening recommendation is for postpartum patients with gestational diabetes? Is it that they have to come in 8 hours fasting for that 75-gram load of glucose and sit for an hour? Or can it just be a random?
Yeah, 2-3 hour fasting test. And that's the 4 to 6 week period ideally, but up to 12 weeks. So it's a huge burden.
Yeah.
And you're waiting there several hours to have that completed. So well-documented reason why women don't want to do that.
Right. It seems like that would be, I just keep thinking like, if I have a 6-week-old baby at home and not eat for 8 hours and then come in and sit for 3 hours at the doctor's office to have the screening test done, I don't want to do that.
Yeah, especially with breastfeeding, that was also something that came up of not wanting to have be away from the child so you can breastfeed, but also having to breastfeed in public in a clinical space, not comfortable for that as well.
Yeah, interesting.
Thank you.
Jeff said we're allowed one more question.
More of a comment than a question. So what you've seen here is 3 pilots selected out of a large number of pilots we have funded using funds from the NIDTK funds and several leverage grants. And here, Marlon, thank you very much. ADA has supported a couple of pilots, and thank you very much. But two trains run across these 3 projects that you've seen today, and this is typical of all our projects. First, strong connection with external partners. They've gone out and sought partners, and all of them potentially fundable through larger grants. I mean, in Kate's case, she spent hours and hours and hours talking to Abbott lawyers to get permission for IPR release. In the case of, similar with Jessica's project, working with Kaiser Permanente for sharing of data, not easy. And in your project, CDC data and dealing with that. And each of them, I mean, like Kate has already submitted an R01, Jessica has already got funded through other means. And your, and Leslie will definitely get funded somewhere. So again, we've estimated the return on investment from our pilots is about 1 to 23. For every dollar we invest, we have been getting about $23 in return. But I think this is where these pilots are a gift that never stops giving. So.
So it's not on the published agenda, but we are going to take a 10-minute break before we move into the panel presentation. So go ahead and take a 10-minute break and come back right on time.
For this last session, Mary Beth couldn't make it today. She had a family emergency, so I was asked to moderate. Not as good a moderator as Mary Beth, so I had to put some slides to help us in the discussion. So, but this is, I hope this can be interactive, and it's going to be about discussing about how do we move our pilot data to the next level. So what works and what doesn't work when we are using our pilot data to apply for grants to write those larger papers. So the uses of pilot studies in general are for feasibility. So we want to know if we can recruit our population. Can we randomize this population? Can we keep the participants in the study? Will these participants do what they're asked to do if they're enrolled in the study? How can we treat? Can the treatment be delivered per protocol? Are they going to follow that? Are there assessments too burdensome? Are the treatment conditions acceptable for participants? And are the treatment conditions credible? So how can we convince? So to get the conversation started, I would like to introduce our panel here. We can maybe start here from my right with Lisa. They are investigators that have received pilot funding and are working on moving that pilot data to the larger grants. So I think it's a great opportunity to learn from their experience. So maybe we can start with Lisa. Can you introduce yourself and tell us about your research?
Sure. Thank you, Francisco. My name is Lisa Staimez. I'm an assistant professor in the Department of Global Health, and I'm one of the faculty in the Emory Global Diabetes Research Center, also in the Nutrition and Health Sciences program. So my research focuses on learning diabetes pathophysiology, learning new approaches to thinking about how diabetes develops, by first thinking about population level data and what we can learn globally across different populations, how diabetes develops, and then delving in deeper to understand a little bit more from a molecular standpoint, how diabetes develops.
Dayna?
Hi, I'm Dayna Johnson. I'm an assistant professor of epidemiology in our Department of Epidemiology here at the Rollins School of Public Health. My research is focused on sleep health disparities. So in general, I investigate different environmental and social determinants that contribute to poor sleep and sleep disorders. And I look at the cardiometabolic consequences. And I have a pilot study that we recently finished that looked at a mindfulness intervention to improve sleep and subclinical diabetes or reduce subclinical diabetes risk.
Good morning, everyone. My name is Ambar Kulshreshtha. I'm an associate professor in the Department of Family and Preventive Medicine. I'm also jointly appointed in epidemiology and hospital medicine. The area of my research work is related to how CVD risk factors, including diabetes, can actually improve brain health. I have to say my career start was actually with one of the grants from Georgia Diabetes Center and the Alzheimer's Association. But in the past few years, I've had like 6 pilot funding on different kind of projects. So I can happily tell you what to do and what not to do.
That's great, Amber. And maybe we can start with you. And then I'm also, I have received pilot funding from the center and have also some experience in, I'm an endocrinologist based at Grady. Amber, how do you think about pilot studies? What is a pilot study? How do you use that mechanism?
So I think the way we should think about pilot studies is not about hypothesis testing first,
and
right?
Maybe you can use your mic just in case.
Yes, it's not about hypothesis testing, but it's more about can you do the project? It's centrally about can you do all the ideas that you have? Can you implement in a small scale and see how it works? So I typically, with this experience of having so many pilots, I tend to think about pilot studies as like a go, no go, or caution, right? So like if you get the data everything is looking good, which is very rarely the case because you have to keep going back and forth, refining the protocol, adding things and taking out things. But ultimately, if the product is good, you can give it a go. And at other times, of my 6 pilot funded studies, 2 were like complete failures. I just couldn't recruit. I couldn't somehow figure out a way to work with the collaborators, which is another reason why you should do a pilot, is to figure out who you can work with. Can the students or staff you hire, can they actually do the work? So all these different side aspects of doing a pilot are extremely helpful. And I feel in our world, when I do clinical trial, there's almost like an RCT impatience because we want to get to this big RCT. But having a pause and maybe repeated pauses just helps to adapt our protocol, refine it better for future success down the road. So I feel like pilot studies are really the most important step for career building and research.
Thanks. A more general question. This is, I guess, a more big picture question to kind of start the conversation there. Maybe Lisa, how can we successfully use pilot data to guide larger studies or grants? Bigger picture.
Well, the feasibility in terms of approach. So down the road, if you're going to be submitting an R01, for an example, the approach is a section where you have to demonstrate that you know exactly what methods you're going to employ, how you're going to do it, and that it can actually be done the way you say so. So you need to be thinking, okay, what kind of processes or data do I need to be establishing or collecting to demonstrate that? So if one of the things is, I can recruit and retain participants in this particular population, then you want to be actually actively analyzing and documenting your success or your lack of success as you go. That process isn't just by doing your pilot study. It's actually constantly touching base with other people who are doing work in this area. So having a pilot study also gives you the opportunity to get reality checks against other colleagues, other clinicians who are seeing the same population, for example, in their own work, maybe for a different reason. Maybe they have a completely different reason for seeing the same people that you're interested in seeing. But doing reality checks is essentially the most important part, I think, of pilot studies.
Right, and you mentioned R01s, which is kind of how we think, or the larger study. So how do we use that pilot data to move it to that next step? And I put here a list of the typical mistakes that we may make with this. So how can we use pilot data and the experience gained from pilot studies to overcome common mistakes in applications for larger grants? So I just got this from the NIH website, common mistakes in writing applications from the National Institute of Mental Health. And for example, in the aims section, what are the typical mistakes that we see? Too ambitious, for example. They get those applications. So sometimes the aims are unfocused. It's not exciting, lack of a compelling rationale, incremental and low impact research. So maybe, Dayna, how can we address this? How can we start thinking forward before we submit that larger grant? How can we think about our pilot addressing those initial kind of steps that we want to make sure we can put together to get that preliminary data to put a compelling grant?
Yeah, I think a great idea is to, one, talk about your pilot study and the results. And so similar to today, where some people like Leslie Johnson was able to present the work that she's doing and to get feedback on it. So sometimes when we're working on our teams, we're all kind of thinking the same way. So to have a diversity of opinion about the study. And another thing that we are doing, at least in the pilot studies that I've conducted, is using a mixed methods approach to where we get input also from the participants, to get an idea about that feasibility only from the study design, but also from the participant side. How was communication? Was the intervention effective? How did you feel about it? And so on. And so the other piece in terms of being ambitious, I think that's probably a problem that lots of us have. We want to put everything in, but that's also a major downfall, really. So in thinking about when you're writing your larger study, if it starts seeming like a lot, listen to yourself, right? And, separate those things out. And I can say from some of the studies we've done, that was one pilot study, we actually learned that it was 2 larger grants. And I have found in my experience, the grants that I've had funding and working with others is actually very simple aims that are the ones, that, of course, innovative and pushing the research needle forward, but the ones that are more simple that you can actually accomplish. Because what you don't want to do is have an overly ambitious plan that you cannot meet. And then you're having conversations with your program officer about why you haven't reached recruitment goals and so on. But if you think about your actual pilot, who you were able to recruit and how often and what it took in terms of your staffing, your funding, and so on, you can better plan and be able to scale that to understand what's likely going to be feasible in a larger study.
Great, thank you. Amber, any additional thoughts? And I think we've all been told too ambitious.
Yes, I've had grants rejected by, with that very comment about being over ambitious. But, if I weren't ambitious, I wouldn't be doing research, right? Our whole goal is to make a larger impact on people. But I think it brings up to the point when we do studies, we collaborate with people, they all bring up some excellent ideas, right? And that is, I'm currently doing, I'm on my NIH training grant, K grant, and I'm collaborating where people want to add on more labs. They want to add on more questionnaires and more imaging markers. All of it seems very exciting and will make my pilot like a dream pilot. The problem is you almost you cannot forget your participant on whom you're adding on all this burden, right? And just because your pilot study was somehow you were able to make it through doesn't always mean you will have a successful larger study too. So involving all the key stakeholders, as Dayna was mentioning, the participants, the caregivers, what it means to them and how they can do it is, I think, very important. So, and I think in some ways you're really developing a critical skill of a PI of how to say no to some people. When your collaborators, add on, another 20 pages of questionnaires that, are well validated, but you just can't do it to your study subjects. You have to really protect and defend your study participants because without them, there's no study.
Right.
I'd like to just add one more thing about this. I think that one of the most instrumental elements of pilot grants is the writing element of it and learning how to communicate your idea. And your idea may not change at all between a poorly reviewed one and one that's reviewed very favorably, but the difference could be just the way that you write your idea and the iterative process of how you define the problem in your own mind. I think submitting multiple pilot grants actually is probably a really good thing because it helps you to improve your writing on that specific research problem.
Yeah, that's great. And I think you guys were also mentioning about bringing the right stakeholders. And here's another list of common mistakes in those applications, the problems with investigators, for example. They don't have enough expertise, low productivity. How can you publish the data from your pilot quickly? You have a year. Sometimes those pilots are short term. So how do you do to keep the timeline and get that publication if you don't have many publications to get that pilot study? How do you organize your time maybe? And then how do you put a team together? A team does, I think the pilot may be a good opportunity to start building a team that is credible and that can help move that project forward. So maybe Dayna, do you have any thoughts on this?
Yeah, so what I do personally when I'm writing a new grant, I think about, of course, first was the research question. And then thinking about that research question, I can think about all the areas of expertise that may be needed, right? Especially with the intention of doing team science, it's important to bring together actual experts. And so, for example, when doing health disparities research, it's really important to have someone that's actually trained and, in the methods or such. So I think about that and then invite, have a conversation with those individuals about the grant and see if they're interested. But the other piece, in addition to expertise, is also having some level of experience with having grants. So in addition, I think, of course, it's, we've all been at earlier stages, but, having some people that have established track records of getting funding in that area that you're interested in will be vital to your success. So making sure to include, some senior colleagues. And then also, while I'm also saying this, it's also important to think about your budget. So, senior colleagues do sometimes take up a lot of the budget. But, think about that role that they will likely play and, balance that with your research team that's going to, really do the work in terms of the data collection piece.
Thank you. And Amber, any thoughts about on putting the data together? Maybe not yet for publication, because you have your pilot, or you maybe finished completing recruitment, and how do you use that to put your grant together? How have you done it before?
So I'll say that when I was working on my pilot studies, I was actually feeling a little bit down that it's very hard to publish pilot studies, right? You're working with such a small sample of 10, 15 participants, and like, who's going to take this paper? The good news is that there are journals that actually target pilot studies. And in fact, the grant that I had from the Georgia Diabetes Center, we were able to publish those results. It was led by a med student and, our collaborative team, which was mostly all trainees other than me. I'm also a trainee, but, I had mostly students working with me. So, so the good thing is you can actually get these studies published. You can focus on very unique aspects of research that are not talked about as much, like what does tailoring of an intervention mean? So we just published on that, like what steps did we take to tailor our intervention to a particular population, right? That was just the goal of our research paper. So yes, we didn't have any great findings from some of our, from the, we can talk about outcomes from the A1C sort of outcome, but the other things about what it takes to tailor, what it takes to recruit, those are great things to talk about in research. And those are some of the key things you can take on to write about very richly in your bigger grant application, your K or your R grant, about what you took from that pilot.
Yeah,
one piece to that. I think it's also important to utilize brief reports in journals. That's a great way to get a publication that, otherwise you wouldn't be able to do an entire original research for. You can write a brief report using the data from your pilot. And then another approach that my group often uses is submitting to conferences. And so again, going back to, my point about getting feedback, but also those conference abstracts are often published and you can reference those in your grant that, if it is a published, or the data that were generated were published as well. And then also writing methods papers regarding your approach. There are good ways that you can, still get them and publish the data in a high impact journal.
Lisa, any other thoughts on this?
No, I think that these techniques are exact, and you have actually just given me an idea because we are about to start a pilot study, and we should be actually looking at journals that publish pilot study data to identify information about the study sample of interest. And we haven't targeted those particular journals in our searches. So thank you for that great idea.
That's a great point. Yeah.
I'd like to add one more thing. I think just as Leslie and others presented over here, pilot studies are a great time to do qualitative research too, because you are really, how you are engaging the stakeholders, what their input is all getting into the input of the design of your protocol and the ultimate intervention, what it would seem like. So, and those kind of qualitative aspects, you can, again, have your trainees conduct after the due guidance. So all those things make, your exercise of doing a pilot very rich. And to be honest, I founded, our clinic was, it was the first time a clinical trial was being done. And I just was like overwhelmed with the amount of work that needed to be done for an intervention study. But the whole process, when I look back at it, was so helpful, not only for the intervention, but all the side benefits you get, or the satisfaction you get from training or your students over there. All the career paths, they all go on to med schools, PhD programs, and stuff like that. I just love that aspect of research, that even if my pilot fails, at least I've launched some careers down the road.
Thank you. So how do we avoid common misuses of pilot studies? And you were thinking about sample size. So I just want to do like a little quick poll here. So we sometimes think about using pilot studies for obtaining preliminary estimates for our next bigger study. So how many do you guys here agree that you can use the pilot study to obtain preliminary estimates? Can you raise your hand if you agree with that statement? 50, 60. Who disagrees? 1, 2. Hell, okay, perfect. That's a great point of discussion. So if you go to the NIH website, it will tell you to not use pilot data for preliminary efficacy or power calculations. And the rationale here is that with the pilot study that you have, you cannot obtain real good estimates because you don't have the sample size to obtain that estimate. So you may obtain a large effect, so a high, so this is the pilot effect size. So you see a huge difference between your two groups. And that's a potential type 1 error. And because of that huge difference, your power calculation will lead to a small sample size. So because you're sure that you're going to see a difference, you probably just need maybe 20 patients to see that difference. So you conduct the study and then you see that the study was wrong, underpowered, not helpful. So that's a potential problem. On the other side, you may have very few patients and you see a very small difference. You may have a type 2 error where you're not seeing that the actual real difference that it actually is there. But because of that, you may end up doing a sample calculation that is huge to try to see that small error when you end up spending a lot of dollars to try to see that difference, or you maybe not get funded just because it's not feasible to conduct that study. So that's why on the right side of the figure, you can see what is recommended is that we actually think about what is important, what is clinically meaningful, and thinking based on that concept, then you should try to calculate your sample size. So the pilot study should be to get the preliminary information about recruitment. Can you do it? Do you have the right setting, etc. And here is, for example, an example of who you should talk to when you're developing your question and trying to come up with an estimate. What is the difference that you want to see between the groups to calculate your sample size, do your power calculations? So talk to clinicians, talk to patients. What is important? What is going to change guidelines? Talk to policymakers. What is the effect of standard of care? The weight burdens, risks of benefits of your potential intervention or study. So can anyone describe a time where a pilot changed the planned hypothesis or the design of a future study? It's a little bit more different. I don't know, maybe Lisa.
I certainly can.
Okay.
One of my pilot studies wanted to test a hypothesis around apoptosis and certain epigenetic markers. And our findings were completely they were significant in the completely opposite direction of our hypothesis. Eventually, that led us to realize that what we were proposing as a potentially very critical biomarker may still be so, but for different reasons related to apoptosis of non-pancreatic cells rather than pancreatic cells. So this has led me to now develop some other ideas, including one that I've submitted for a KO1, looking at certain epigenetic mechanisms in non-pancreatic cells for understanding type 2 diabetes in youth.
Dayna?
Yeah, so for a pilot study that we did as part of my K, and then now in my R01, we had to make a change. So in my K, we had our participants did 48 hours of ambulatory blood pressure monitoring. So they wore a cuff and it went off every 30 minutes during the day, every hour at night for 2 days, and they hated it. And, so we talked about that. They told us about it. And so now in my R, we give them a day off. So we do 24 hours on, 1 day off, 24 hours on. So, just having that flexibility to make a change. And then I'll just give another brief example from our pilot study. For the mindfulness study, we did focus groups and asked the participants about, so our participants used a mindfulness app where they did different exercises every night to reduce stress and anxiety before bed. And so we asked them about these experiences, and we found that our racial minority participants were, they wanted instructors for the mindfulness that were of their same race and gender. So that concordance was really important. So, and for us now designing the RL1, we're looking more for apps that have a diversity of instructors that would allow that flexibility, because that's clearly something important that's going to affect adherence.
So, of course, when I think about pilot studies, and changing aims, I've had, when you propose a research hypothesis, you have some sub-aims. I've definitely let go of some aims. In fact, I got feedback from the NIH reviewer that you need to add objective measures of stress. So stress was one of my exposures, looking at cognition. And they were, we said they are not very good objective measures of stress, like lab measures like cortisol. But the reviewer didn't really wanted it. So we said, okay, we'll do it. But now when I'm collecting the data, the process of collection of data, as well as what it really carries weight in terms of the lab measure, I decided I can't do this. This is, not worth our effort to collect and pay for those kind of testings. So I think I've always tend to, drop some hypotheses, like sub-aims, which are either becoming too cumbersome or not meaningful enough. Like, I do a lot of work now in vascular testing, and there's so many measures. Like you open up, some literature and there are like 10 biomarkers, 10 ways to do things. You can't do it all. And sometimes something that seems promising, more literature comes in and you feel like, okay, it's not promising anymore, so I need to drop it. So I think I've definitely dropped sub-aims when I just feel like the time, effort, and value of doing it is not enough. So, there's a great thing in research and business world is that for pilot studies, you should try to fail fast, safe, and I'm forgetting the last part of it, but you should definitely, make sure that, anything that you're failing at, you quickly take it out and move on with the rest. So.
Great. And the final list here is that when you were talking about the approach, Lisa, and how can you use your pilot study to kind of visualize that larger grant that you're thinking, because you're trying to get your preliminary information. So here, common mistakes, too much unnecessary experimental detail, not enough preliminary data, no expertise with the approach, inadequate considerations of power, et cetera. You can see a long list of common potential mistakes. How can we use this approach, using this money to start thinking forward of what we want to avoid in our larger application?
I mean, I think it's actually like a great idea to come to a list like this when you're developing your pilot study, and think very big picture as you start getting more narrow in your thought processes. Personally, I think all elements of the approach have been improved for me through the process of pilot grants. That includes institutional support. So we've had some pilot studies where we've had to move locations 3 times. We're doing work in global settings, and we don't always end up being able to do the work that we say we're going to do, because other things are happening in the world, and political support influences science sometimes. And so how do you pivot, and what kind of, how do you develop? One thing you should be considering when you're doing your pilot studies is how to develop institutional support. So when something goes wrong, you have a way to fall back on something related, but maybe in a slightly different way.
Dayna, do you have any additional thoughts on this?
No, I don't have anything additional to add. I agree.
I have to say that when I'm a reviewer for pilot grant, this is the most fun thing to do because you can always criticize a pilot. It's just so many ways you can, nitpick on things and all that. But, you have to allow pilot studies a grace because, it's most of the time junior investigators, sometimes even seniors do that to just, again, test the environment and everything. So again, I would say, as far as mistakes go, be very careful about, the budget part of it, because, in our current environment, hiring of research coordinators, hiring of interventionists and how long you're supporting them, those you feel like you can do it. And the more, you when you start to implement things, it becomes like a very painful exercise to actually execute things. So, build a cushion in your budget for all those variables that can happen throughout the process. And actually, that one thing I wanted to actually do a poll, if you allow me, is how many feel that you should have a comparison group for a pilot study? Yes. Well, so but so the intervention, most intervention studies when you're doing a pilot, you don't really need a comparison group. So should you put some amount of your budget in a comparison group it still comes up in debates and discussion because what are you, again, comparing it to? But I would say as far as possible, if you can, depending on, again, as Venkat said on your research question, think carefully about whether is it worthwhile to put money in a comparison group, because you're anyway not going to get any idea about efficacy to begin with. So why spend that money over there? So those are kind of decisions you have to deal with that reviewers also nitpick on.
That's a great point. And you were touching on budget, and on this website, the next section is on budget. I didn't put it here, but you can go also and take a look at what all the mistakes that we do when we are thinking about budget. So this is more for the audience, and we just have a couple of minutes. We don't want to extend. So what are some of the challenges that you have seen in your own research applications that have make it difficult to use that data effectively? And I think we have people at all the levels, from the more junior to the super power investigators here.
Yeah, I just want to point out one very serious common mistake. That is an investigator believing that the preliminary data is data generated by herself or himself. That's not what they're talking about, I think. I think what you're really talking about is what preliminary data there are in the field to support the significance of your application and the feasibility of your application. And if you have generated some of your own data to fill in some of the gaps, and that's why you should look at a pilot grant as a strategic resource to identify those gaps and go after those rather than answering a question. Like the one thing that you said, the doctrinaire that you can't use pilot data for planning sample sizes, is partly true and partly wrong. The place where it's true is you can't use pilot data to come up with an effect size, but you can use pilot data to measure variability in measurement, which is required for estimating sample sizes. So I think it's a matter of thinking about pilots as to how you utilize it. Like, for example, in Lisa's pilot grant that became a K, which is likely to get funded, she assembled pilot data from several sources, some that she had generated herself, some that came out from the single cell lab, some that came out from others that generated. And again, Dayna and I were talking about, I think that you need to be intelligent here. It's not, it doesn't say that you have to do the study yourself before you do the R01. That's a very conservative approach, and it leads to pilotitis and low risk research.
I love that. And I think going back always to what is the important research question and how do you answer that question and how do you get your preliminary data and using this mechanism. Any other final thoughts here?
Like the giant in the field here, you can hear now from the minion. So I just have a question though. So as a PhD student, I'm constantly learning new things all the time. So please, I hope this is not too simple of a question. Many, many times in this panel, you guys have talked about taking a pilot study and making it bigger, making it bigger, a K, an R, whatever. We're not just talking about like a larger sample size, are we? Like we're talking about, you can make it bigger in many different ways. You can expand aims, but is the most common way of taking a pilot and making it bigger just expanding expanding the sample, or
Not necessarily. Yeah, because you can use this to get amazing information for analysis of secondary data with a small budget. If you and that can be use the pilot mechanism, it can answer the bigger question, but maybe that bigger important study can lead to a next level question or next grant that supports that field. That's my take. I don't know, Mo, do you have any other thoughts on that?
I'll just add that I think, yes, everybody is envisioning a big study down the road, but doesn't mean your first pilot data collection will get you there. So in my case, you know, my the current study I'm doing is actually a build up from my previous pilot. So still a pilot. I'm just adding, I've just refined my protocol more, and I've been able to add new things, take out some things. So it's a series of steps before you get to that larger great sample size. Again, as I said, I think most of us are in a hurry to get to that R phase, but you know, grant funding agencies, if you justify to them well, you can actually, for the same idea, get another round of pilot funding if you justify what you are doing new and how much you're expanding. So you can go from a 30,000 to a 200K grant before you go to your, you know, million grant.
And just another piece, and it may not be one pilot study. I can say for my R01, we did at least 2 pilot studies plus secondary data analyses from large cohort studies. So, you know, you sometimes are piecing together, you know, aspects. And I had a pilot study that was just focused on understanding one aim of a larger study that I did. So, you know, it can have many functions, and you know, and you just have to think about what do you need at that time to get you to the next study that you want to do.
Great. Yes, Liliana.
Yeah, I think.
Oh, but we can hear you if you just have. Yeah.
Yeah, so we might want somebody more senior to answer, but I can say at least for my current R01, I use pilot data from my K, which was 5 years. You know, some of it was from 5 years ago. And so if you think about the trajectory that can be outlined, right? Like a K01 or a career development award could be 5 years. You may not write that next grant until your 4th or 5th year. And so it's designed in that way. So by the time, you know, you write an R01, you might need to resubmit. That can be 2 years later. And so personally, I've never been penalized. I mean, honestly, I work a lot with Jackson Hurst study, and that data goes back to 2000. So I have not had an experience to where they were like, oh, these data are too old. I've had that with manuscripts, but not with grants. I don't know if others have.
I can add something over here because it depends on, again, your research question, as Venkat was saying. But in my area, you know, if you're in a biomarker field, you know, something where things are evolving very quickly, so you have to be careful that something that you had proposed 5 years ago might be completely either already established or out of the door, right? So you have to be careful. Is your old pilot data relevant in the current times? You know, so.
Perfect. And I just wanted to end, because we're beyond time, with the resources that the center has. And I think we've talked about collaborations, we've talked about pilot studies, we've talked about mentorship, and I think those are all the things that actually the center provides. And here is Jeff. If you guys are thinking about a potential application to an R01 or a grant, can reach out to him, present the specific aims. He can link you to the investigators that can provide you advice about that grant application. We have studio consultations. Take a look at the grant funding mechanisms that the center has, and And please reach out to Jeff at any time or any of us here. So thanks very much, everyone. And I don't know if there's any other thoughts.
I'll just add something. So I want to give a shout out to Mark because, when I dropped the word clinical trial, the amount of work that it involves getting clearance of so many offices and, making sure you're registered here, registered there is like so much of bureaucratic work. Mark was extremely helpful in, helping me get started with those aspects. So yes, great resources that you see here.
Yeah, agree. Mark is a pillar. So, yeah. Well, thanks everyone.